Let me just start recording. So what I did this weekend, next week we do have a quiz. Can't remember exactly what it says it's on. Probably this content maybe, and I can't remember exactly. But we do have a quiz next week, as I'm pretty sure. And then we're talking about cancer and organ transplant and renal disease. And those are two really hefty topics. And so what I did was I recorded the renal disease one already, and I just haven't posted it yet. And it was about 45 minutes. So it is not like a super short lecture, and cancer is probably somewhat similar. So what I want to do is I want to get through, we'll do the quiz, and I want to get through the cancer lecture, and then I want to revisit important things from the organ transplant renal lecture, but do watch the lecture. So I posted it, I'm going to post it today. I'll post it probably right after class. So I'm posting it like a whole week early so that you guys have time to listen to it at some point. So you'll have this week and essentially next week to listen to that lecture and be caught up on that content. You know what I'm saying? So that's how I'm handling that, because I just feel like it's better than trying to pack it all in a crazy hectic way. Yeah.
I just want to clarify, it's just one.
It's just one lecture, and it'll say recorded, you know, renal disease or organ transplant. And I'll post that. I will post that probably in this week and in next week. I'll probably post it in two different places, but you know that you can find it for sure in week 6 because it's technically week 6 content. I'm just giving it to you early so that you don't feel like, so just so you have more time to watch it and make notes on it and think about it and mull it over and whatnot. So today we're just talking about pregnancy. So this hopefully will be kind of a lighter lecture and may or may not take up the whole time. So hopefully you'll have time in class to work together on the handout. So I like this when we don't have like an overbearing amount of content and we can do the worksheet and kind of think about it, critically apply it and have time to discuss. And it just doesn't always happen that way because there's so much information. So the chapter was chapter 46 for pregnancy and oral health. And these are the objectives from the chapter. So pregnancy and oral health, critical role in education. So when you have a patient who's pregnant, you sort of have a really great opportunity to talk to them about several things. You obviously can talk to them about their own oral health and how it relates to their pregnancy, but you can also talk to them about their oral health and how it relates to the oral health of their baby that they're going to have in a short period of time. And then you can also talk to them about the oral health of taking care of a young child. So you have like lots of things that you could talk to them about, and they're going to be kind of a captive audience because most women who are pregnant care a lot about their pregnancy and they care a lot about the baby to come and they're excited. And so they want to learn about it. And so whether it's their first baby or maybe it's not their first baby, but maybe they just haven't learned about it, it's a prime opportunity. So we kind of call it like a teachable moment. You have, you know, they're more excited or more open to learn just because of where their stage in their life. Physiological changes increases susceptibility to certain conditions. So talking to them about the hormonal changes and how those hormonal changes they may see signs of that in their mouth. For instance, they may be more susceptible to gingivitis, where they might be doing their regular routine, and whether or not their regular routine was enough in the first place may or may not translate into the health that they start to see in their gums at that time. Because say they were sort of, you know, average to lackadaisical on their flossing, but they never really had any problems. But then when they're pregnant, they may all of a sudden exhibit some problems that they didn't see before, some bleeding or some swelling. And so just the state of being pregnant can affect those things. So opportunity to work collaboratively with other healthcare providers. At the end of this, I added some neat little examples of hygienists who actually work in OB offices or who work at, pregnancy centers and actually practice hygiene in those centers as providing care, but also as screeners and educators. And so it's a kind of a fun opportunity to integrate yourself into the medical field, but also to collaborate and educate practitioners who, OBGYNs or, anyone who works specifically with women who are pregnant. Okay, so some terms. So prenatal, occurring or existing before birth. Teratogen is an agent or a factor which causes malformation of an embryo, and it's early, so it's within the first 10 weeks. So they consider something a teratogen if it's could affect the fetus within those first 10 weeks. Organogenesis, the formation of the organs, occurs during the first 10 weeks of pregnancy. Gravid is just another term meaning pregnant. Gestational diabetes, we talked a little bit about that in the diabetes section, and diabetes that develop during pregnancy and it's not present prior to. So if you had type 2 diabetes prior to becoming pregnant, they don't call it gestational. They only do it if it's developed during pregnancy. Oral health literacy, you recognize this term from other courses, I'm sure. The degree to which an individual have the capacity to obtain and to process and to understand basic oral health information and services needed to make appropriate health decisions. So do they have access to, can they understand, can they comprehend the information they need in order to make a healthy choice about their health? And then a teach back method, we'll talk about this with other populations as well, but it's a communication method used by healthcare providers to confirm whether a patient understands what's being explained to them. So it's actually kind of a little time consuming. And who's used the teach back method in other classes? I see some of you, yeah, some of you, and you do it in clinic. Yeah, exactly. Yeah. So when you talk to them about how to floss, and then you say, now show me. And another way to do it too is if it's a verbal education thing, you can, the way healthcare providers use it is they'll talk to them about a situation and their recommendations, and maybe something that they have to do at home, or like a follow-up. And so they'll give them a lot of information. And this is also very, very helpful with elderly patients or somebody who maybe has mild cognitive decline. You don't just, it can be utilized in healthy individuals for sure when you've just given them a ton of information, but it's also really great for somebody that if you're not 100% positive if they processed everything, then you say, well, I've shared a lot of information with you today. Can you let me know what are some of the big points that you remember from what we talked about? Or there's also like a better way too, where you're not putting them on the spot and saying, this is a task. What did I just say? But tell me how what you understood about what we talked about today. Or there's some better wording that I'm not grasping, but that's basically for them then to repeat the key points. And if they forget something like, take your medicine in the morning only, then you can say, oh, great. And remember, you also want to take your medicine in the morning, not in the evening, or something like that. So it gives you an opportunity to correct what they heard. So that's the teach back method. And so you can utilize that in all different situations. Okay, back to pregnancy, trimesters of pregnancy. So there's 3 trimesters. First trimester up to 13 weeks, second trimester 14 to 27 weeks, third trimester 28 to 40 weeks. In the first trimester, the fetus is most susceptible to the teratogens like we already mentioned. Oh, I have some notes there. I always look at my notes because sometimes I just don't remember to read my notes, and I have something important, and it might be repeated in another slide, but it's important for dental hygienists to assure women that oral health care during all trimesters of pregnancy is safe. Obviously, some things we're going to postpone unless it's an emergency. But even if they're in their first trimester, coming in for a cleaning is perfectly safe. So for both themselves and their developing baby. So it's important for us to reassure them. Dental radiographs, if it's an emergency and there's proper shielding, they could have a dental radiograph at any time. But obviously, if they're in their first trimester, we're not going to take bite wings. If it's just routine, we can postpone that. It's not a necessity, and we can just postpone it. But almost everything we do, if it's an emergency, can be done safely. And so they don't ever want to put stuff off, especially thinking like when they're in their second or third trimester and they just think, well, I'm just not going to get my teeth cleaned this year because I'm pregnant. That's probably like the worst thought that they could have, because they might think it's somehow not safe, and it is perfectly safe. Okay. So educating the pregnant mom. So we're talking about that. And have you guys got this with Kristen, right? Vertical transmission and horizontal transmission. Do you remember this? No, maybe, yes, no. Some of it's, you get a lot of information. So here we just repeat it again, just if you did get it. Vertical transmission of the strep mutans is from mother or the primary caregiver to the infant. And so we like to remind the mom that if their oral health care, if they're going to be the primary caregiver, if they're there most of the time with baby, their oral health is really important, because a lot of times that from kissing and, licking something and then transferring it, like there's so many things that moms do that if you don't have a kid yet, you might be like, why would a mom do that? But moms just do that. And so, but they can transfer the level of strep mutans in their saliva, in their mouth. They will inoculate the baby. So if there is a lot of bad bacteria in their mouth, that they're going to transfer that to the baby. And so it's imperative that they keep their oral environment as clean as possible, flossing and brushing and taking care of decay, any areas of decay, so that they don't transmit a heavier load of bacteria to the baby. Now, that's not the only way it can happen. There's horizontal transmission of the strep mutans. So there's family members or another child, like an older child maybe in the house grabs the sippy cup and drinks off of it, and then, or the bottle, and hands it back to the baby. So there's other ways that bacteria can be transmitted as well. So improving the mother's oral health will in turn improve the child's oral health and their rate of disease. So a lot of times you don't see, like you may see, like, I don't know, in the waiting room before, you might see like maybe the baby's pacifier falls on the ground or something, and the mom like wipes it off or like spits on her fingers and then wipes it off or something and then shoves it in the baby's mouth. So there's, you can think of any numerous ways that those bacteria can be transferred. And so it's important to educate the mom on those topics, and the dad and the grandma, just to share that information with the family. Periodontal disease and preterm labor. So this one is a little bit sort of up in the air. I've gone to some really good CE courses where they presented this as just sort of closed science, where women who have periodontal disease do have a higher chance of having a low birth weight or a preterm baby. But really, I think the science is not settled on this. There's this Cochrane review, which, that's supposed to sort of be sort of the creme de la creme, because it's a huge review of all the literature that's out there. So in 2017, there was a Cochrane review that showed no specific relationship between babies born before 37 weeks and whether the pregnant woman received periodontal therapy or not. So say they had periodontal disease and some of them had the therapy or scaling and root planing to try and reduce the load of bacteria and settle down the active periodontal disease. There was that group, and then there's women who just didn't have it and maybe just had a really inflamed periodontal state the whole time they were pregnant. They didn't really get statistically significant results showing that one camp was better than another. However, there is still literature out there and studies that have shown that women with periodontal disease have a higher incidence of low birth weight or preterm delivery, and that and it kind of all links back to those inflammatory markers in the body, and how when you have strong inflammatory markers, it can kind of affect different systems in the body. So for instance, Pitocin is what they give women to induce labor. And so there's inflammatory markers that sort of mimic that, or sort of have a similar reaction in the body. And so if there's a lot of that flowing through the body, the hypothesis is that your body is like, oh, maybe I need to go into labor, because it has a similar effect, or the body sees it as similar, some of these inflammatory markers. And I think I have the details of those in the notes. The IG, maybe it's in the next one. It might be in the next one. So approximately 40% of pregnant women have some form of periodontal disease, so it's kind of a high percentage. And then systemic reviews have found associations between periodontitis and adverse pregnancy outcomes. But then I said the thing about the Cochrane study. Oh, this is where it is. This is what I was thinking of. Okay, so preterm or low birth weight infants, those are sort of the big results that negative results that you wouldn't want to have happen. You know, typically you don't want a low birth weight baby, and you don't want them to be premature. You'd like them to come after 37 weeks when they're fully developed. Research has indicated that periodontal infections may be a possible risk factor. So it's just what they're sort of looking at and analyzing, similar to other things that can trigger things in the body like cardiovascular diabetes. They're just looking at this as yet another connection or possible correlation. So the topic is under debate, more research is needed, but the theory is, like I was saying, infection causes a quicker increase of the prostaglandin E2, so PGE, and tumor necrosis factor alpha. So these molecules can theoretically induce labor, is what they are concerned about. The prostaglandin is similar chemical structure to Pitocin or oxytocin, which is what your body naturally releases when a woman goes into labor as well. So they might induce labor in the hospital, but when you go into labor naturally, that's what your body's producing to get it going. And so that whole cascade of events, they think, can trigger it early. And then, so non-surgical periodontal therapy is safe and effective during pregnancy, especially during the second trimester. So if you see a patient in their first trimester, say you see a new patient, she's in her first trimester, and she has, a lot of inflammation, maybe some pocketing, maybe heavy calculus, don't be afraid to recommend that she comes in if she wants to wait until her second trimester when she's feeling better. Usually that second trimester is like kind of like the magic trimester where suddenly you have a little more energy, you're not nauseous anymore, and you're not so big that you're just like, oh, I feel like, weighed down by this baby pushing on all your organs. So it's kind of like this little hiatus you get in your second trimester. So if women feel that way, you can recommend that they come in and get their deep cleaning at that time. And so don't be afraid to recommend that. Questions so far? Yeah.
I know I'm reading that it says infection that causes, are you talking about the infection that they can get from like the mouth?
Yes, so
infection that causes
we're specifically talking about periodontal infection. So the prostaglandin and the tumor necrosis factor, that would be, so whenever you have a chronic infection in your body anywhere, your body is sending these signals, the inflammatory signals. So these are specifically ones that are being sent from this chronic infection in the mouth. It's in the bloodstream, and it's the body's kind of being signaled, that something's not right. And those particular molecules are very similarly structured to the same molecules that trigger labor. So that's the hypothesis. Yeah. Okay, So oral manifestation during pregnancy. So pregnancy gingivitis, an increased inflammatory response to the bacterial plaque during pregnancy causes signs of gingivitis. Typically more in the anterior region. You'll see like the marginal redness in the maxillary and mandibular anterior. Peaks during the third trimester, so just when everything is just rocking and rolling. And then women may have gingivitis prior to pregnancy. Women who have gingivitis prior to pregnancy will have a greater chance of having pregnancy gingivitis. So if they're already struggling with some maybe mild gingivitis, that maybe they don't even really notice, like you would notice it because you're the clinician, and you can pick up on the signs of inflammation, even if it's just mild. But if they have that, even if they're unaware, it might really tick up during pregnancy. Let me see if my notes say anything good here. I don't think so. Okay, another thing that can happen is this benign oral gingival lesion. Here it's called oftentimes it's referred to as a pyogenic granuloma. This guy over here, my mouse is not going over there. That's funny. Sorry, my mouse is like nowhere. It's not on my laptop or over there. There it is. Well, it's not wanting to go over there, but you can see it. The swollen area between 23 and 24. So a lot of times, so if this happens, if they get a pyogenic granuloma, it's not a big deal. A lot of times, if it's left alone, it will resolve after pregnancy. And again, it's just sort of a reaction to all the changes, the hormonal changes in the body. I have talked with doctors or heard from patients who got them removed. They became very large and they were sort of either weirded out the patient or they were getting in the way of maybe eating, maybe it just kept bleeding, it was in the way. So they got them removed during pregnancy and they grew back within pregnancy. So like fast, they can be fast growing. So if it's not really troublesome, doctors would probably just leave it and then either remove it after their pregnancy is over, or it will kind of go down on its own. So, but it's nothing, it's not cancerous, it's not anything to be worried, it's just more like a nuisance. And then tooth erosion is another thing to think about for this population if they have a lot of morning sickness, either throughout the pregnancy, because that's a long time to have a lot of regurgitation or vomiting. And some women do have pregnancies where throughout their whole pregnancy, they have nausea and vomiting. Usually it subsides by week 13, by the time they're done with their first trimester. But even if they have a lot of morning sickness just for those first, usually, your first 4 weeks of pregnancy, you just don't even usually really know anything's going on. So sometimes morning sickness doesn't start till week 6 or 8. So they might have like a good month, a little over a month of morning sickness if it's, kind of a more mild typical pregnancy, but it can vary. Everybody's different. And so that, continual acidic environment can cause erosion even in that shorter period of time. So the best thing to recommend is, of course, rinsing their mouth after, if they vomit, to rinse their mouth out. And especially to use something like baking soda and water rinse, because that neutralizes so well. And so that would be the best advice for them. And then to avoid other kind of acidic foods while they're pregnant, maybe, although I loved lemons. I was like lemonade every day for me. So that would have been torturous because I just craved it. But I suppose if, you're rinsing out your mouth, it's okay. But also acid reflux as well. I had really bad acid reflux toward the end of my pregnancy. So if somebody has that, then again, neutralizing the acids in the mouth is really, really crucial. Dental caries and tooth mobility. So an increase in dental caries has been associated with the frequent carbohydrate loading, consumption of sugary drinks during pregnancy, decreased attention to oral hygiene care if they're just tired, and especially if it is a difficult pregnancy, or if you have other children to care for, or anything, you can just imagine a hypothetical and realize how exhausting it could be. And so oral hygiene may lax during this period. And also decreased attention. Okay, no, that's it. So just if you have them in the chair, encouraging healthy snacks, encouraging water. Their doctor's already harping on them big time about drinking plenty of water. That's what, a huge thing that the doctor wants to make sure that the patient's doing anyway. So you know that you're in tandem with them about increasing water intake. And of course, snacking is important. They need to fuel, like they may be hungrier more often, especially with a baby, demanding their nutrients. So, but encouraging healthy snacks, complex carbohydrates, fruits and vegetables, things like that. Tooth mobility. Increased tooth mobility has been associated with microbial shift from aerobic to anaerobic bacteria, and these shifts are accompanied by increased inflammation in the attachment apparatus, as well as mineral disturbances in the lamina dura. So it's really interesting, and this condition appears to reverse after pregnancy. So it's really interesting because I have had patients who have suddenly had mild mobility during pregnancy, and they were freaked out because maybe they had really good oral hygiene, maybe tooth mobility wasn't anything, and maybe they only noticed it like in their anterior teeth. But it can be something that maybe just you notice because you're checking mobility, but maybe they notice it too. But the good news is, like all these other kind of freaky deaky things that can happen during pregnancy, your body tends to recover just fine and go back to normal. But that is another thing that may or may not happen. Many women don't experience it at all, but that is something that can happen. And then back to periodontitis. Untreated gingivitis can progress to periodontitis, which is characterized by, as we know, progressive and irreversible loss of alveolar bone and other surrounding connective tissue structures and So encouraging them to be fastidious during their pregnancy for all the reasons that we've already talked about. Let alone not wanting periodontal disease to progress and lose support of their teeth. Oral disease prevention and health behavior during pregnancy. So these are just things that you'll discuss with your patient. Staying hydrated. You can encourage tap water over bottled water in order to receive fluoride. But that can also depend on where they are. Some tap water tastes horrible and they might not want to drink it. So then if they don't like tap water, then just simply encourage them to, maybe swish with a fluoride mouthwash or something like that. Meticulous oral hygiene, twice daily brushing, and proximal care. Limited fermentable carbohydrates, sugary drinks, like we said. Do take the prenatal vitamins. So encourage them to, ask them if they're on. When you're going over their medical history, they should be saying they're on a prenatal. And also a lot of times they'll do the prenatal with the DHA as sort of a new, and sometimes it's in the vitamin, but sometimes it's a separate thing, but that's sort of a new-ish, probably getting close to 20 years now that they've been recommending that. But so just, and if they're not taking it, ask them why. They may say something like, oh, my stomach's so upset, I throw up when I take my vitamin. And then see if, encourage them to talk to their doctor about finding an alternative, because there are certain things in a multivitamin that the baby really needs. They could be low on especially like the folic acid. So there's things in there that are really important. And then other things that just in general help for a healthier pregnancy. So it is important for that reason. So if they confide in you, they don't, then you can use that as an opportunity to encourage them. Fish is highly recommended for pregnant women, although there's a whole, go look at 46.1 because there's a whole bunch of fish that you don't want to be eating when you're pregnant. So that was part of what the books added as something important. But I mean, I took like fish oil or like because I don't eat meat, so I didn't eat any fish, but I did do other things that had omegas and the things that are in fish that are healthy. And you certainly want to avoid the fish that are higher mercury level. Chlorhexidine and xylitol can also be recommended. So these are safe for pregnant women and could be really important to them if they have gingivitis of chlorhexidine and xylitol. There are wonderful studies out there about pregnant women and xylitol who they took like a cohort of women who did a regimen of like 3 times a day xylitol mints or whatever it was. It was like a total of 1 gram of xylitol throughout the whole day, and measuring their strep mutans against women who didn't. And then the babies, like 6 months after, like they tested the baby's oral cavity for levels of the strep and the mutants, and it was amazing. Like women who not only had good oral hygiene, but just maybe their oral hygiene wasn't even affected. It was just the xylitol. I can't remember. You can look up these studies, and they really did affect the levels of bacteria and the transmission. So it really is a wonderful thing to recommend, I think. So barriers to care, low levels of oral health literacy. So whether or not they understand the importance of all of these issues, if they can understand the importance or the concept of what we're actually, breaking it down into a simple way so they're understanding the concept. Cannot afford dental fees or co-payments, so they may be not coming in because they can't afford it. Dentistry is getting nothing but more expensive these days. Do not understand the impact of oral health on their general health. Simply don't think that there's a connection there. Difficulty in finding a dentist who accepts Medicaid and or pregnant. I can't imagine there's a dentist out there who wouldn't take a pregnant woman, but there's probably somebody. But I mean, that just seems nutty to me. But but Medicaid, not accepting Medicaid is something that I can see totally. I mean, that happens all the time. Office hours are not convenient for those who work. Obstetricians and nurse midwives often do not urge pregnant women to seek dental care. So that's where we have a huge role in educating these, there's midwifery in Portland. There's lots of sort of, I don't know what to call them other than just midwife groups, and so a pregnant woman might only see them, they might not see an OBGYN at all, just see the midwife. And so you can go and you can work with these groups and discuss and educate and make sure that they're aware of these important issues to pass on to their patients who may not see a traditional doctor. Fear of going to the dentist because of past experience, uncertainty about whether the dental care is safe during pregnancy for the woman and for the baby, lack of transportation, lack of childcare if they have other kids at home. So there's lots of barriers that could prevent somebody from coming in. Professional oral health care during pregnancy. So pretty much most everything that we would do is totally safe. Within reason, we might wait in the first trimester because unless it's emergency, why? There's no reason to, especially if they're tired and nauseous. That is alone a reason to postpone it to the second trimester. Consult with other healthcare providers as necessary if you have questions or concerns. If there's anything about their pregnancy that doesn't seem totally normal or common, or something just seems a little bit more high risk, like with everything, call the physician, call the doctor. There's no reason to just move forward without feeling totally secure that what you're going to do is going to be okay. Pregnancy and poorly controlled pre-existing diabetes is a risk to the baby's developing organs. And so you want to make sure that if you have a patient in the chair that either has type 2 diabetes or has gestational diabetes, that you are able to maybe not going to a big in-depth discussion, because I promise you, if they're with an OBGYN, they're getting a lot of education on that anyways, but just being aware of that. And so sharing, especially if they seem like they don't know or are asking. So gestational diabetes develops during pregnancy. This is just review. We know this we already discussed this, usually around the 24th week of gestation. So it's a little bit farther along in the pregnancy, and the prevalence of gestational diabetes is can be as high as 9%. So it's not uncommon. And then be prepared to educate patient on the bidirectional relationship between oral health and diabetes. So that's another good opportunity for education. How you guys doing? You tired? You need some cheese soup? That's what I heard. Like, you need some cheese soup? I don't have it. Did you crave cheese when you were pregnant? I wanted chocolate milk and lemonade. Just all the time. Now we can't stop talking about cheese. I know. Cheese is good. That's all Lola wants is cheese. I'm like, you can't live on cheese. I'm sorry. I know. I don't, but pregnancy is weird because people can crave very odd things. So but that's what I mean, they say sometimes it is like like if there's certain things like that have higher iron that are kind of odd, and if pregnant women crave them, that means they need iron so yeah, I think there is. And I think there is truth to that. Like they're trying to get something. Okay. We don't have very much more, and then we will do some activities. We'll take a break here in a minute too before we do the activity. I always want to like do like a stretch break, but I never remember to. So anytime you want to stretch. Okay, so here we go. Moving on. Did I already do that one? Okay. So talking to patients about their medications too, like over the counter. When they go to their doctor's going to give them a handout that says these are the medications that are typically safe and these are the ones you don't want to take. So most women are going to be well versed on this, but if you know it as well, in case you get, maybe a very young mother that maybe is just thrown off by all of it, or maybe just somebody who didn't really pay attention, or whatever the fact is, the more good information that somebody gets from multiple sources, the better. So over-the-counter and prescription drugs, herbs and supplements, you want them to understand what's safe for the patient to take while they're pregnant and nursing. So in the book, table 46.3 has good information. They still use it. I mean, even though this was 5 years ago or more, 7 years ago. Oh my gosh, 7 years ago. The Food and FDA, they changed it from this category, category A, B, C, D, and X is like and in oral med we talked about if it's category C, or there's a certain level where no, you can't have it. The other ones are cautionary. They actually changed it. Anything that's new is coming out with this pregnancy and lactation labeling rule, PLLR, and it replaced the letter category of the A, B, C, D, and X, but it's only on like updated stuff. So you still kind of have to know the categories. It's almost like for this time you have to know both. But to be honest, I've never seen anything like they say that it exists, but I haven't actually seen anything really that goes along with it. I still see stuff that goes along with the category. So I don't know, but that's what they say they changed. Here is a list of, it's tons of information on one slide. So, but this is a list of do's and don'ts. But so for pain relief, for analgesics, Tylenol is the one that generally pregnant women can have. Pregnant women can have Tylenol. So if they have a pain, if they have a headache, if they have something, that you can give them, or maybe you won't give them, but you could say, well, feel free to recommend a Tylenol, but they probably know that. They probably have it. If they, Tylenol with codeine or hydrocodone and oxycodone, all of these, we would never be recommending or prescribing, obviously, but they may be used in pregnancy. If opioids are used, prescribe the lowest dose for the shortest duration. Well, we don't prescribe, but nowadays, I mean, they're so opioid cautious that, I mean, this would be something that would be handled by anybody besides us. If we see that we have a pregnant patient that's in our chair and they're declaring that they're on like a hydrocodone or Tylenol 3 or something with codeine or an opioid, we might inquire about it, because I frankly would be interested, or like maybe not surprised, but I'd be like, oh, what are you taking that for? And how long are you taking it? Just to be more curious about what a doctor would be prescribing that for. But like it says, they may take it during pregnancy. There may be reasons. But obviously that's not anything that we would have to prescribe. And it's, you would anticipate that it would be for a very short duration of time. While they're pregnant. Yeah. When they're, yeah, my mother-in-law, she's a nurse and she did home visits for many women and babies who were in detox period, detoxing babies. Yeah. While they're pregnant, that would be very detrimental to the baby. But they're stronger once they're out. The baby's strong, as opposed to like, yeah, wow. Well, you're pregnant. Yeah. Oh, it's so interesting. Yes. Yeah. Yeah. Yeah, they are so resilient. I mean, baby, like all the cellular turnover and everything is firing. Like it's amazing, and so they are hardy little things, and it's a miracle that that's. I mean, it's wonderful that's because there are so many kids that get born into situations, and they just have that ability to rebound or come through it. Thank goodness. You're so smart. You're just a whip. Smart as a whip. And beautiful. Okay, so things to avoid: aspirin, ibuprofen, naproxen is an NSAID. They may be used in short duration during pregnancy, 48 to 72 hours, and avoid during the first and third trimester. They put me on something weird. I had one pregnancy where I was on bed rest, and they put me, I think it was an NSAID, and I kept saying to them, "I'm sure I could take this," but I was in my second trimester and I was in the hospital on bed rest. And they're like, "Yes, this is the second trimester. It's safe during this time." So it must have fallen in this category. But I was like, Antibiotics, amoxicillin, cephalosporin, clindamycin, blah, 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 may be used during pregnancy. Cipro, clarithromycin, these other ones are to be avoided. So it's best to probably remember the ones that are safe: amoxicillin, cephalosporin, clindamycin, metronidazole. That's going to be one for yeast infection, right? Metronidazole, and then penicillin, amoxicillin, penicillin, those two sort of overlap. Tetracycline, never, and we know that, right? Because that will cause the staining in the teeth. So never, never, never tetracycline. And everybody at this point should know that, but you never know. Somebody might forget and prescribe it. Local anesthetics with epinephrine may be used during pregnancy. I don't know if anyone looked at this slide deck earlier, but somewhere I had seen where they had put epinephrine is like contraindicated for lactating mothers, and I must have read a study. I looked and looked and looked and looked, so I was trying to update the information, and I couldn't find that everywhere I looked. It said anesthetic is fine within reason, with caution, only like if really necessary, but not you don't have to avoid it. And so I changed it because I could not find anything that showed like negative. Everything was just sort of like, like use. Oh, yes, Maria, go ahead. Mm-hmm. Do they recommend it, you think?
fall to prevent preeclampsia.
Really?
I was told this as an
For the whole pregnancy then? So starting at 12 weeks and, okay, thank you for that. So 81 milligram aspirin. Okay. Thank you. Okay, so nitrous oxide. So this, we'll have another slide with nitrous oxide because there's conflicting information. I feel it looks conflicting from the macro lens of the textbook. May be used in pregnancy when topical or local anesthetic are inadequate. Pregnant women require lower levels of nitrous to achieve. Consult prenatal care health professionals. Now, that being said, I don't think anyone's going to be giving very many women nitrous. There are many things that call it like a contraindication for the most part. And there's another slide here that we'll talk about it a little bit more. They do use nitrous in labor and delivery, you know, but obviously that's at the tail end, the baby's about to come out. And there are things that say that if a woman is in her later terms of pregnancy and there's no other options, that it's safe to use a certain dose, like less than 30 minutes and stuff. But I just don't think that if you have a pregnant woman in your chair and you're going to do SRP and she's like, can I have nitrous? I would just say like, no, no, because I just don't, you can say that. Like I worked for a dentist who didn't like nitrous. Dr. Andreotti, he teaches up at OHSU now, but he retired from private practice, but he didn't like nitrous and he wouldn't pipe it into his office. And so patients would come in and be like, can I have nitrous? And he's like, oh, I don't like it. I don't have it. And that was just him. You know, so you don't have to give it to people. And if your dentist is in disagreement and there's some strong, you know, waivers or backup, that's their decision. But in general, I don't think I've never given nitrous to a pregnant woman. But I don't think it's like the worst thing on the planet because obviously they've given nitrous to women who are pregnant, especially in labor and delivery. So it's just a weird topic, but I don't think you'll find yourself administering nitrous to pregnant women. So antimicrobial mouthwashes, these may be used during pregnancy. Use alcohol-free products during pregnancy. Okay. Modifications to dental hygiene appointment in the afternoon during the first trimester and early part of the second trimester due to morning sickness. So typically morning sickness can happen in the morning, but people can also get afternoon sickness. So kind of find out from the patient when they feel the best. Ensure that the head is higher than the feet, frequent positioning changes, and then a small pillow under the right hip to turn the patient slightly to the left to relieve dizziness or hypotension. Because what happens is as the baby gets bigger, they put pressure on the vena cava. What is it? Is that what it is? The inferior vena cava. And so I used to do ultrasonics, the 3D 4D ultrasounds, the keepsake ultrasounds. Has anyone ever heard of those before? Nobody, and only people who have been pregnant have heard of them. So where you can see your baby. So I used to have a business where I did that, and all the women were usually up, you know, semi-supine. But sometimes the best position to see the baby was them flat on their back. And I had a handful of women that were like, ooh, like got really, because we're like trying to see the baby. And so you're focused on like getting this good picture of the baby. And all of a sudden they're like, I don't feel so good. And I was like, flip over on your left side. And then they recover very quickly. But you're kind of like smushing out some of the blood supply. So you want to get them on their side and then they feel better very quickly. But that can happen in your chair because the best way to clean someone's teeth is with them lying on their back. So they may just need to kind of tilt to the side a little bit just to relieve that pressure. Dental radiographs during pregnancy. Radiographs are safe when abdomen and thyroid are shielded. However, the healthcare provider, we always want to do a LARA. So if if it's, like I said, if it's just routine bite wings and happens to be their first trimester, just put it off to the next, especially if they're overall healthy. If they're high risk for caries, schedule them to come in maybe. If you're not comfortable doing it in the first trimester, schedule them to come back in a few weeks, or just shield them up really good. So it's, that can just be between you and the doctor. Use the fastest imaging. We do that already with our digital. Hopefully your beam is collimated rectangle, but I guarantee it won't be. It'll be a circular one because I've never seen the rectangle out in practice. Proper film exposure, we don't have to worry about that so much anymore, but back in the day, if you didn't expose it right, then you'd have to take another film, but nowadays with digital, a lot of this stuff is improved. Use of protective apron, thyroid collar, limiting the number of images, so just taking what's diagnostically necessary. The fetus is especially susceptible in the first, so that's why we said all those previous things. No radiographs exposed in the absence of clinical signs and symptoms, or just for the heck of it. Like if you can put it off and they're overall healthy, just put it off. It's not the end of the world if you take an X-ray, but with everything, it's better to err on the side of caution for everything. If diagnostic radiographs are required, utilize the apron and the thyroid collar. This is repetitive. And if you are pregnant, if the hygienist is pregnant, then you can wear a lead apron and wear a dosimeter, but you can also just wear a dosimeter and just make sure you're out of the room. Or even if you don't wear a dosimeter, I wore a dosimeter the whole time I was pregnant and it never came up as anything. And it was a very open clinic. So as long as you are 6 feet away behind a wall, you can be guaranteed you're not getting radiation. It will be absorbed into the walls before it ever hits you. But if you want to be cautious, which I did, and so I wouldn't begrudge anybody that, because I just wanted to see, just order a badge, a dosimeter badge while you're pregnant. Local anesthetic, avoid elective treatment during the first trimester. Use local anesthetic judiciously, so just not using more than you need. And then per the ADA website, this was just 2 things I pulled off of ADA. Preventative, diagnostic, restorative dental treatment is safe throughout pregnancy. Local anesthetics with epinephrine may be used during pregnancy. That's per ADA. Here's more on nitrous. I have a bunch of stuff in the notes just because I feel like there's contradicting information. It is a relative contraindication. Jenny, there's your term relative. You've been vindicated. It was relative versus absolute. Okay, I looked it up and you were right, Jenny.
Wait, are you in the middle of a podcast?
Now I'm angry. I probably, do you want that point back? Because I think, so you're like, it would, okay, so contraindication. So when I went to school, either I didn't listen very good, which is entirely possible, or they just didn't talk about it in terms of absolute and relative. And so I was looking through Darby and Walsh because I'm like, what are they talking about, absolute and relative? And then it is throughout the book where they talk about something being an absolute, like there's never an exception. And you guys, I see shaking your head. So those of you who have remembered this from other courses, I just never really had that hammered into my brain. Or because when I was in school, we just were like, contraindicated just means you just didn't do it. So it was a more definitive term, and maybe it's evolved over the last 25 years. And so now it's like absolute or relative. So like, we don't really want to do it, but this is when we never want to do it. So to me, it's kind of a little, so this is, I guess, a good example of a relative contraindication. Like people can do it, but in general, you don't want to do it if you don't. If you don't have to, the bigger thing is don't do it. But if you did do it, it's not like category X where it's going to cause massive, some kind of deforming, of the baby or something. But there is no FDA rating for nitrous. Studies demonstrate with prolonged exposure, there are problems, especially I think for women who are pregnant. or women who work in an environment. So women who work in a dental office and are exposed to nitrous at low levels for a long period of time, there is studies that talk about miscarriage and maybe some birth defects, congenital abnormalities, altered immune response, spontaneous abortion. Offices must maintain scavenger system in good working order. That's very important if you work at an office that utilizes nitrous to a high degree and you're childbearing age, or you are going to plan on having kids, to make sure that there's a very, very good scavenger system. And then this exposure, no longer than 8 hours per week, 50 parts per million of nitrous in the air. There's measurements. They should have some kind of a measuring, I suppose, attached to the unit that you could verify that measurement. Single low dose exposure, no more than 30 minutes in the second or third trimester, considered safe. So if it is an absolute necessity and the woman is in her second or third trimester and it's going to only be utilized for a short period of time and the physician and the dentist are in agreement that it's okay, that's what it says. So kind of a weird one there. There's a little bit back and forth. In the notes, I put other sources. But like I said, as a hygienist, I've never had to make that choice. So I would always make that choice in tandem with the dentist. What? Who's low? Me? Uh-oh. Uh-oh. We better hurry. Let's go into overdrive. Okay, lactating mothers, we have to think about medication in the breast milk. Breastfeeding mothers should avoid aspirin, but maybe not. I'm going to look into aspirin. NSAIDs, tetracycline. NSAIDs are your ibuprofens, your naproxen. Cipro, metronidazole, Flagyl is metronidazole. And these vancomycin, these other medications, benzodiazepines, those will end up in the breast milk as well. So you'd have a sleepy baby if you took that. Nitrous is considered safe when someone's breastfeeding. That's not going to affect the breast milk. And there's no evidence to interrupt breastfeeding after the use of local anesthetics. So epinephrine, there was something I read that showed epinephrine in the breast milk, but then I couldn't find it at all. So I had to take it away. Obviously, we would discourage alcohol use during pregnancy, inquire about drug use, alcohol use, tobacco habits, and counsel them if necessary. Fetal alcohol syndrome can damage the central nervous system, affects motor skills, skin and muscle innervation, and behavior aspects of personality. So there are massive permanent damage to the baby if the mother drinks alcohol. And some studies have said even like getting drunk once. And I think it's a very different, some women get pregnant and they don't know they're pregnant, and maybe they've gone out and had a few drinks and that didn't result in anything. So I think that they don't know exactly what and when, but in general, it would be something to highly avoid during pregnancy. I don't want to not get to these interprofessional collaborations. This just talks a little bit about the different ways to collaborate, but if my thing shuts down, go back and look at these slides and the links to these two examples that I put in here. This one is the Michigan Initiative for Maternal and Infant Oral Health. It is RDH, that should be RDH. It's an RDH in an OBG clinic. They provide on-site preventative care, education, and referrals. It's presented as part of the prenatal care. So the patient has to opt out. Otherwise, they're just going on to you next. So they're going to go see the doctor, the nurse, and then they're going to go to see you unless they purposefully opt out. It requires a committed RDH leader. So it really takes somebody it's like working with the older population. You got to have a passion for it, but there is definitely a whole industry that can be opened up to you if this is your passion. If pregnancy and pregnant women is something you're interested in, then this can be a whole thing for you. There's a design dental op in this one place in Michigan where they do treatment. The RDH serves as a case manager, follow-ups on referrals, and et cetera. So you're not just helping the woman that's pregnant, then you're following up on her afterwards and her kids. So it's an amazing kind of triage education role. So education, public health, champion, even cheerleader, encouraging hesitant patients to seek dental care, helping them to find a dental home. So that's one example. The link is in the notes. Another example is in Wisconsin. There's this grant that the state has given them. It's an investment in this Wisconsin Medical Dental Integration Project, and they're creating a new model for primary care clinics in Wisconsin to help change the outcomes. Through the project, which started in 2019, medical clinics can dovetail brief appointments with a dental hygienist for a young child waiting for immunizations or a pregnant person waiting to see a physician. By maximizing time management with routine medical visits, the hygienist can provide a risk assessment, fluoride varnish, oral health education, and coordinate follow-up care as needed for children and the pregnant person. So that could be another job in a medical practice. So I just think these things are cool. These are the kinds of things that really excited me as I had practiced for 10, 12 years and was starting to get a little bit bored and wanted to do something new and different. There's so many opportunities to just get creative, and you can find a niche in whatever area you have interest in or you feel excited about. So there's the links in the notes there as well. So I'm going to stop sharing. We can take a nice little break and then we'll come back and do the worksheet. So 10 minutes, so come back at 10:15.